hang out um, hang out with a thank you hang out with a small crowd here live, but it's special because we have a special announcement by our from some of our team members. So I'll pass the mic to Shema to say hello and to tell you what they have in store.
Hello, everyone. So as I guess a few already know me, and just introduce myself. I'm so excited, so you can already see it. I just introduced myself. So hi, my name is Shema, and I'm a 50 medical student, and basically we have a very small announcement with respect to the schema project that is already known in CP Solvers. As you know, there's already the Portuguese project and the Spanish one, and now we started to launch the German one today. And before I say more, I just wanted to give a brief story about how I came in how I had my first encounter with CP solvers. It was basically 2 years ago when I came across the first schema that I saw. That this was the ascites schema, and I was just so impressed. I was like, what is this? Like, from which side? And then I came across what CP solvers is. I mean, I know that this was a podcast, but I didn't know that VMR existed during that time. And then just later, like 2 years later, a friend of mine and also a student from my university, Anita, who's also involved in this project, together with Sammy, and she showed me the whole VMR. This was just like a few months ago, and knowing that I would be involved in this project with these amazing people is just mind-blowing, and I'm so grateful for this team. And it's also all thanks to Maria, who approached me just in January asking me whether I'd be interested in this project. And I'm just so grateful for to her that she had so much trust in us. And yeah, Maria, you're amazing. And also huge thanks to Sammy and Anita. Without you, this whole project wouldn't be what it is today. So yeah, I'm passing the mic.
Yeah, Shema, thank you so much for those nice words. I'm also a long-time CP Solvers fan. I think 1 year ago, I joined VMR for the first time in life and presented the case to Ravi, and he just basically completely dissected it and got the diagnosis, and it was really a tricky case. You can listen to it. It's severe hyponatremia. I don't know which episode it is. And I was always so afraid of joining VMR, but I listened to every episode. And yeah, now during this year, I joined more often and became more part of this great team. And I'm also just so thankful for this opportunity and to work together with Shema and Anita. And we're really motivated. We translate a lot of schemas into German. I really want to take the message that CP Solvers has and spread it around the German-speaking medical hospitals, for example. And yeah, I'm just so thankful, and maybe I would pass the mic to Anita if she's here.
Oh, yeah. Yes, I'm here. Thank you for passing me the mic, and thank you all for thank you, Shema, for offering me the participation in this project. I'm not a team member for a long time. I've joined VMR about 6 months ago after passing my last, second to last state exam, and it's a bit like step 2 USMLE, but the German version of that. And after that, I've decided to be a part of to listen to CP Solvers, and it fascinated me a lot. So I pushed Shema into joining, and Shema was, yeah, she joined, and she was very, very happy. And then she offered me to join the German project. So yeah, actually, at the moment we're working in translating the schemas, the schemes into German, and we plan to also do the videos. And maybe we thought of inviting you, Rabi, and maybe organizing VMR in our university. Yeah, we would be very proud. Yeah, that's it from my side. I'm happy to join the VMR.
Anita, that's so kind of you to say. You made me blush there with that invitation. It would be an honor. And hopefully we can continue to learn from your institutions. Instead of saying more words, I'm just going to show you how unbelievably incredible these folks are. Just take a look at this. So this is, as Shema was outlining the timeline, it's only been a little bit of time, really. But here, the link is in the chat. Look at this. These are all the schemas that these three people have translated. It's unreal. I'm still going. We're still only at M, by the way, only at M, and we're going and we're going and we're going all the way down to cirrhosis and shortness of breath. See, I can guess what that means. So you all are doing an absolutely incredible job, and it's a treat to bear witness to it. And I think, we're very, very grateful for it. The opportunity is an opportunity that you all created and ran with. So thank you so much. It's a real treat, and I'm glad that more people know about it, and hopefully this will catalyze your project even more. Okay, you all ready? This is going to be a very different global VMR. And the truth is that if you're here joining live and you were hoping for a session where on a Saturday morning you could kind of sit back, relax, learn, not participate, you can still do that, but I'm going to make it very hard for you not to be actively engaged. Very hard. In fact, the goal is to make it literally impossible for you to be actively engaged, to not be actively engaged. How are we going to do that? I'm actually going to present you a case that kept me awake at night for a little while. Not really, I sleep like a baby, but it was really illuminating. So if you are willing to play along in this clinical reasoning simulation, please turn on your video if you can. If you cannot do that, then type in the chat. Okay, all right. The chief concern is shortness of breath. And the truth is that real life means, and for many people, real life means there's about 2 to 3 minutes between when you see the chief concern on the main triage board until you see the patient. So when you hear shortness of breath, I would love to know what your first thought is. Just your first thought, the first thing you think about when you hear shortness of breath. And I'll mute and see what wisdom comes through the chat. Hans, tell us more, please.
Yeah, when I heard shortness of breath, I was right away thinking maybe there's something wrong with the lungs, like a PE, but also vascular problems. There could be insufficiency of the heart. It could be, and now it depends on the time course, many other things like infections, malignancies. So we might probably have to ask the patient whether there are additional symptoms like nausea, vomiting, or even pain, which is indicative of an MI, to rule out any red flags right away. So we have time to investigate further.
Amazing, Hans. That is there's so much richness there. And you're really taking us down about 10 or 15 thoughts, quite honestly. And it's hard for our brain not to think of all those things at the same time. But part of the exercise we're going to go through today is literally, what is your first thought? The first and most important thing you want to know. Thoughts? What would be, if you would only have one thing you could think about, what would that thing be? Marcella, what's your sense?
So I was thinking about that, and I graduated like some months ago. So I started working in the ER, and I was in the ER yesterday. So if someone like a nurse tell me that we have a patient with shortness of breath, I will first think, how severe is that? Beautiful. Do I need to intubate the patient? Do I need to wait or just to put in the emergency and see the saturation or something like that? It's the first thing that comes into my mind.
100%. Hans has his diagnostic antenna up and laid out a tremendous way of getting to the bottom of it. And you have to do that in parallel with understanding that there are many morbidities that lie within the world of shortness of breath. Now, the truth is that if somebody comes in with thumb pain, you're not going to think what are the most severe causes of thumb pain, because you know the probability of a serious cause is low. But in the world of dyspnea, the probability of a serious cause is high enough that your first thing is, what do I need to do to protect this patient from devastation, right? And so you'll see that the theme in clinical reasoning is we have a small number of concerns for which the morbidity is so high that we actually don't care about diagnosis first. We care about treatment. And examples would be chest pain, shortness of breath, abdominal pain, acute neurological changes like stroke or seizure, things like that. And we should work to develop what that list is. It's probably not very long, but for another time, we're like, what are the conditions in medicine, or the chief complaints in medicine for which doctors tend to RX before DX? And it's probably not that long, but dyspnea is definitely one of them. So let's go to that space. I'll ask you another question. How do we gauge the severity of shortness of breath? What is our and I'll give you a hint, this patient's shortness of breath is going to be pretty severe, so we should practice this. How do we gauge the shortness of breath? I'll mute and see what thoughts come in the chat. Oh, beautiful. There's so much wisdom there. Tiago, do you want to share what your thoughts are?
Oh, yeah. I think that when you see the patient, you can easily notice their ability to speak and the respiratory rate. I don't mean counting the respiratory rate, but you can see how it's going. Also, you can easily put the finger to get the oxygen saturation. So I think in a few seconds, you can get a big picture.
Absolutely superb. I couldn't agree more with you. And Rafa is thinking along similar lines with getting, basically there's this progression of description of how bad the problem is without the O2 sat. And that description can be, oh, I only have it with exertion as the most benign thing. I have it at rest. I have it so bad at rest that I can't even finish the sentence, right? There's a spectrum. And Sammy has mentioned similar things with the respiratory rate, how much you need to move. And then all of you are also alluding to mental status. And the mental status relates to the fact that you can be so fatigued that you get confused from your dyspnea. So what's our job here? Our job is to see that there are actually two themes here. Everything that somebody's saying, everything here falls into one of two themes. And those two themes recognize what the lungs do. So what do the lungs do? They bring in oxygen and they expel carbon dioxide. So the gauge of severity falls under one of those two things. Now, some patients have both, mixed respiratory failure, but most patients have one thing much more severe than the other. Pure COPD, CO2 problem. Pneumonia, O2 problem. And some people have ARDS, a little bit of both. But it's good to actually have a list of severity based on what pathophysiology perturbance is at play, why it affects the treatment, and we'll talk about that. So O2 severity, Tiago said it, 100% easy. Just measure the O2 sat. There are times where the O2 sat is not reliable, like when a patient is hypotensive or their extremities are cold or they have methemoglobinemia, but it's a good initial, very good initial test. The gauge of CO2 problems is what's called the work of breathing. So we don't have a immediately available bedside test like the O2 sat for CO2 retention. So what we do is we study the patient's work of breathing as a parallel to how much they need to work to excrete carbon dioxide. And if they only have shortness of breath with exertion, they probably don't have CO2 excretion problems. But if they're working really, really hard and their O2 sat is normal, they probably have a CO2 problem, right? So we go down this schema and we say we know that it's not the oxygen. All the things that everybody else mentioned is an excretion problem. Dyspnea at rest, dyspnea exertion, not speaking in full sentences. And altered mental status is the final stage of that, because altered mental status doesn't accompany hypoxemic respiratory failure. It accompanies hypercarbic respiratory failure, right? So the symptoms that you all were saying, dyspnea at exertion, dyspnea at rest, not speaking, being able to speak full sentences, and then the final stages, you get so hypercarbic that you get confused. But then remember that in addition to this subjective line, there's also some very concerning findings here with your stethoscope. Now, what would those findings be? Markers of airway obstruction. So if you have silent chest or stridor, you know your patient has hypercarbic respiratory failure. Why? Because hypercarbic respiratory failure in most people is an obstruction problem. And you can have such severe obstruction that your airflow doesn't flow in your chest here, or such severe obstruction that you start to get stridorous. So to answer the question and merge everything that everyone has said, you have to step back and assess severity of shortness of breath. How do you do that? The subjective portion is usually done to assess hypercarbia. Why? Because you have a much better test to understand hypoxia, and that's the O2 sat. You don't need to talk to anybody to understand their oxygen saturation. So you break it down, O2 sat for the hypoxemia. If your patient has normal O2 sat, all the other data is studying the risk of hypercarbic failure, which initially the most mild is dyspnea with exertion. Most severe is AMS because of such hypercarbia that they no longer can compensate for it. And there are 2 exam correlates, which all suggest really severe obstruction. So let me tell you what this patient had. This patient came in with incredibly severe dyspnea at rest, not able to complete sentences, O2 sat, normal. Okay, that's all you know, is this is severe O2 sat, normal. What questions do you have for me now, based on what we talked about?
I didn't quite understand if O2 sat in the ABG, which is done through the fingertip, or through ABG in the blood, or the fingertip measurement.
That's amazing. That's a really, really good reflection. So what times would prompt you to worry about the O2 sat not being reliable? You know, when would you think, oh, I don't trust this O2 sat?
Well, if the patient has nail varnish, it's like the most simple thing.
Correct. All right.
Carboxyhemoglobin.
Carboxyhemoglobin, superb. Anything else that you can think about to the whole group? You name 2 of the 3 big categories. There's one other category too. So nail polish, carboxyhemoglobin, and then one other category too. So basically, your O2 sat is unreliable when blood isn't getting there. So hypotension or Raynaud's. When the hemoglobin molecule is poisoned, carbon monoxide, or when their signal is not making it to the probe, nail polish. So break it down into, I can't measure the O2 sat because there's no blood getting to the finger, hypotension or Raynaud's. I can't measure the O2 sat because there's something on the hemoglobin messing it up, carbon monoxide, or I can't measure the O2 sat because there's something in the way of the signal. One of those 3 things. And I will tell you here that none of them are at play. So the finger perfusion is great. And you can tell based on the waveform of the O2 sat that it's pulsatile. So blood is making it there, that the patient doesn't have a headache, doesn't have redness to worry about carbon monoxide, and you can see there's no nail polish. You can also tell the waveform is really good. So first you're doubting the O2 sat. I'll tell you here, you can trust it. There's no reason to doubt it. Waveform is good and there's no nail polish. So your patient's severely short of breath and has a normal O2 sat. Let me ask another question now. What do you want to do to support this patient? What are your options to help a patient who is so short of breath but has a normal O2 sat? Giving them oxygen is not going to help. What do you think you can do? What are our options to support this patient? First, do an ABG. Can you tell us why, Anita?
I would evaluate if it's a respiratory or metabolic problem.
Yes, beautiful. 100%. You have now, in this case, 100% Tiago, you've diagnosed a CO2 problem or a ventilation problem. But you have to be careful. The patient may be having a dramatic response to a metabolic acidosis, and their work of breathing is only compensatory and helping fix a devastating metabolic acidosis, or they have a severe respiratory acidosis and you need to help them. So the first step is to understand, is this a compensatory dyspnea or is this a pathological dyspnea? What tools do you think you have on exam while the VBG or ABG is pending for 2 to 3 minutes to help you figure out, is the lung protecting the body from some other problem, or is the lung the problem? What tools do you think we have? The smell of the breath. Tell us more, Sam.
Yeah, for example, if patients have metabolic acidosis due to various causes, for example, DKA, they can have certain types of smell, and there's also certain poisons. When you poison yourself with those, they have specific smells associated with them.
Absolutely beautiful, 100%. Angelita, I know you can't unmute. You said you were on a night shift. You were saying typer breathing and Kussmaul. It's very easy to tell when somebody is breathing phenomenally well. You put your stethoscope, you hear very loud, pure breath sounds with a big, big tidal volume, massive expansion of the chest, excellent collapse of the chest, and a fast respiratory rate. That person is compensating. If you put your stethoscope on somebody with hypercarbic issues, you will hear some perturbance. Their lung expansion will be impaired. Their lung collapse will be impaired. So you can literally watch the lungs. And if they're doing a phenomenal workout, big, small, big, small, big, small, metabolic acidosis. If you intubate that patient, you have to be very careful. Because if you are intubating somebody who's doing massive exercise, for a small period of time, you're not going to be able to match their respiratory rate and their tidal volume while you sedate them and intubate them, and they can code from an acidosis. So you have to be very careful. In stark contrast to the people who are breathing poorly, they're at lower risk of an intubation-related code because they're already working poorly. So Anita, you're 100% right. You need a pH to confirm your suspicion, but the simple stethoscope will tell you, what is this lung actually doing? Is it doing a great job? Or is it doing a rapid, shallow respirations? Bad. Respirations with stridor or wheezing? Bad. Your stethoscope will answer that, but you should confirm it with a VBG. So I'm going to tell you, this patient, you listen to their lungs and you watch them. I'll just tell you, you watch them and they're doing not great. You can tell that their lungs are not working well. So what options do we have to support a patient who has likely hypercarbic respiratory failure? What can you give them to help them feel better while you wait for your data to come back? Brilliant. Tiago, do you want to share more? Superb answer.
Yeah, I think that, as you said, we should improve the ventilation. And if the person is awake, the best way to do it is to give positive pressure by BPAP or CPAP, whatever you have. There's a great thread, I'll put it here in the chat, from an emergency doctor just telling about a patient with asthma. Yes. And he was, yeah, I'll just put it here because you can use it probably more than we use it, because the threshold for intubation, sometimes it's low and it can cause problems once you intubate a person, as you said, because you need to have a big tidal volume, and the person is unconscious. So if they are conscious, it's very good to give positive pressure and just let it work as the nature does.
Superb, superb. This is why we make many mistakes with this issue. We make many mistakes because we are so used to hypoxemic respiratory failure, and we have so much room to give people excess oxygen. Nasal cannula, face mask, face tent, high flow nasal cannula. There's so many ways you can slowly escalate oxygen therapy. The bridge to intubation for hypercarbic respiratory failure is much shorter. You don't have many options. You need to open the airway, and you can try pharmacological therapy, bronchodilators, steroid, magnesium, Heliox. But if your patient is this sick, you should give positive pressure right away. You need to be very aggressive with airway obstruction because the options are much shorter. You don't have all these oxygen delivery modalities. And the mistake that happens with these patients is they get put on oxygen. They get put on, no, we'll give 4 liters, we'll give you 5 liters, maybe you'll feel better after 6 liters, 7 liters, but their problem isn't oxygen. Their problem is ventilation. And if you can't pharmacologically dilate their airways or put positive pressure, you have to intubate them. One really important thing for these patients is positioning. You have to help them use their diaphragm as efficiently as possible. And the best way to have optimal diaphragmatic function is to move the stomach and the abdominal contents out of the way and have the patient sit upright. So don't lay these patients flat in the bed. If you lay them flat in the bed, their stomach will press their diaphragm and it will be harder for them to breathe. So sit upright, bronchodilator, and if it doesn't work in 5 or 10 minutes, BiPAP, CPAP, preferably BiPAP. And we won't touch on that nuance. So what are the lessons in this case? Dyspnea, as Marcella reminded us, severity first. It can be very morbid. Severity is calculated in 2 parameters, oxygen severity or hypercarbia severity. Hypercarbia severity is captured in the conversation about work of breathing, and the end stage of which is altered mental status. It also is captured by watching the mechanics of breathing. Inefficient mechanics, as inferred by the depth of breathing or pulmonary auscultation, should make you worry about hypercarbia. But remember, dyspnea can be a protective response from severe metabolic acidosis. So watch the patients that look like they're at the end of a marathon, where they look very short of breath, but you can see they have rapid lung expansion, excellent collapse, and good work of breathing. Those patients, you support them and fix their acidosis, not fix their breathing. Okay? Any questions about any of that before we move on? So let me tell you, don't you worry. If you sat through 30 minutes of Saturday VMR and you're like, did Robbie have a stroke? He's talking about RX and not about DX. What's going on? Let me tell you, this is an incredibly intriguing diagnostic mystery. But let's start with the exam. So he's afebrile. This is a real life story, by the way. I don't know anything about him except this data. His heart rate is 110. His BP is normal. His respiratory rate is 32. And his SAT, as I told you, is 98%. And he has no stridor. And he has marked wheezing. Severe wheezing, almost silent chest. Okay. My dog is worried about this patient, clearly. Okay, I'm gonna pass the mic to you all. How old is he? I don't know. Honestly, he looks like a middle-aged patient. I don't know. You've seen this, Rob. It's triage room. You don't know him yet. I'll tell you more in retrospect. Right now, he looks middle-aged. He looks pretty healthy. He looks athletic. He doesn't look like he has chronic medical problems. He looks pretty healthy visually. And this is what you see. Where would your thoughts go next? Superb. So Thiago is reminding us again, give him bronchodilators and move quickly to BiPAP if you need to. Beautiful, Sammy. Awesome. Hans, do you want to take us on what you think of as causes of wheezing? So we're supporting this patient. We're giving him bronchodilators. We're going to use BiPAP. What do you think of, Hans? And I'll come to you in the line right after Hans to finish off his thoughts.
I don't know what causes the wheezing, but now we have the wheezing schemata in front of us. That is not all wheezes are asthma. So we have to look for something within the entire airways, which might be pressing from outside, from inside, or whether there is anything from a poison that has injured his trachea. Basically, everything is possible. Unless, of course, we are able to smell anything, so we get an idea of what Sammy told us.
Yes, I love that. Use your nose and your eyes and your stethoscope. So you taught us that wheezing is an obstruction problem, be it internal obstruction or external obstruction. Beautiful. Nalayan, can you share your thoughts too?
Yeah, sure, Abhi. Am I audible? I hope I am. So from my medicine auscultation classes, what I remember is that wheeze are of two types. We have monophonic and polyphonic. And in reality, I don't know how they sound alike. What I do know is monophonic is usually when there is only involvement of simple bronchi. So when I think of monophonic wheezes, I think of more like foreign body aspiration or simple cases of aspiration. And when it's polyphonic, I would think more in terms of systemic pathology, something that involves multiple bronchi at the same time, could be bronchiolitis. Or if we are going more upstream to involve the bronchioles, I would think asthma.
Oh my God, absolutely poetry. I love that journey based on the nuanced nature of those wheezes. Let me give you some more information. So what happens in real life is you look at him and you're like, maybe we can get away without BiPAP for maybe 10-15 minutes. That's all I'm willing to risk it. So as Nina recommended a long time ago, we get a VBG and we order usual labs, chest x-ray, usual labs. And the first things that come back are VBG is a pH of 7.2 with a PCO2 of 75, roughly. His x-ray is negative. You don't see anything on the x-ray. It's normal, no hyperinflation. Anything you can think of is completely normal. And you give him a bronchodilator for 15 minutes and you're like, okay, I'm going to come back in 15 minutes and I'm going to go review his chart. So now you learn that he's 65-year-old man. He has no medical history whatsoever. He goes to his primary care doctor, takes no medications, and has nothing relevant in terms of his family history. It's like a chart that even though he has access to care, completely empty chart. And so you go back and talk to him, and the good news is he's normal. 15 minutes later, one dose of bronchodilator, and he looks like he has no problems whatsoever. And you're shocked. You're like, this man was, I thought I needed to maybe intubate him. Gave him 10 minutes of bronchodilator, only one. I know he had a true ventilatory issue. And this is why, Anita, I recommended you confirm it, because our assessment is imperfect. I'm so glad I got a VBG, because the differential diagnosis of if the VBG came back normal, I'd be like, maybe I'm crazy. Maybe he wasn't that had hard work of breathing, and I'm having a bad day. So I'm glad that we confirmed it. We confirmed he had a ventilation issue, but it's normal. And then you do a repeat VBG again at this time when he's normal. pH 7.4, PCO2 40. Crazy. So I told you this is a diagnostic riddle. What does he have? What's going on? I'll just mute for a little bit and get your thoughts. All right, Sammy, you want to share yours?
Yeah, I was also really shocked about this rapid onset and rapid response to therapy. So I was also thinking maybe there is some anatomic lesion that causes this decrease of blood entry into the air entry into the lungs, but it would be not the first thing on my differential. But I don't know if you can respond that fast if you have, for example, a huge asthma exacerbation. I don't know that.
Absolutely beautiful. Yeah, you're saying that he has an episodic, as you said in the chat, dynamic airway issue. It's very different than fixed airway issues like a foreign body or COPD. So your schema is wheezing, airway obstruction, and now he has dynamic airway obstruction. So you made a lot of progress there. Nalayan, you had two really good thoughts. The first was about panic attack, and the second was about angioedema. Do you mind sharing those?
Yeah, sure. Initially, I think the panic attack very closely mimics MI in the term that the patient might have a hyperventilation and the feeling of doom, and they often also have a chest pain, which is more functional than structural. That could have been a differential, but Thiago very rightly pointed out that it would induce hyperventilation and then the CO2 would be rather down than what we have right now. And as Sammy pointed out, of a dynamic obstruction. So I thought of angioedema case, I think it was a recent NEJ case as well. So if there is edema of the endothelium lining of the respiratory tract, that might be reversible. So that would in turn be a dynamic pulmonary obstruction.
Superb. I love that initial point. This is why, if you will listen to anything today, listen to what Anita said from the beginning. You have to get the VBG here, because your assessment of ventilatory performance, great or imperfect, is not pristine. So you could say, oh, I think he has work of breathing issues, but you could have been wrong, and he could actually have phenomenal lungs. And a low PCO2 on the VBG would be like, wait, hold on, no bronchodilator, no nothing, I was wrong. Maybe he has metabolic acidosis, maybe he has aspirin toxicity, maybe he has a panic attack. So you engage your differential diagnosis for respiratory alkalosis and you leave the lungs alone. Here, this shows you that you were right, that he actually needed your support. And then your second answer is, again, you're giving us a great differential diagnosis of what causes dynamic airway collapse. And angioedema is a really, really important, angioedema anaphylaxis is a really, really important point. Okay, I will put up a schema in a minute to illustrate this concept. But I want to hold this moment for a second for any other thoughts that people have had. So we have tracheomalacia, we have angioedema anaphylaxis. What else? Marcella, do you want to unmute and share your thought?
Yeah, I was thinking maybe like a drug-induced bronchospasm.
Beautiful. I think drugs being at play is really, really important. As a group, can we think of any medications that cause bronchospasm? Yeah, Shami, do you want to share?
Yeah, I learned in med school that you should really be careful with beta blockers in patients with asthma and COPD, because via beta-2 receptors, the smooth muscles relax, and therefore the lungs can better inflate. And if you take away this mechanism, you can really put those patients into hypoventilation. Beautiful,
beautiful. Rafa, you had another thought too.
Yeah, thinking about like step one, thinking like what are the receptors in the bronchial tree? And I have to remember the beta receptors and the muscarinic receptors, and the beta blockers cause constriction as well as the muscarinic agonists.
Incredible. I love it. And Alexander, you also another link with another medication. Do you want to share it?
Hey, everybody.
Hi.
I was talking about the rare Stamper's triad, like NSAID-induced asthma.
100%. I read this recently. They updated the name to aspirin exacerbated respiratory disease for reasons I haven't explored yet. And NSAIDs can trigger that just as much as aspirin. I love it. So it's a certain patient population. What if your patient has, if you pretend that your patient has a heart rate of 140, they come into the ER and the ER does something to them, normalizes their heart rate, but they get bronchospasm. You know what drug is missing? What drug could that patient have gotten? Starts with an A and ends with an adenosine. Adenosine is a prominent trigger for bronchospasm. We worry a lot about it. I've actually seen it once. And you start to see that the list here is things that can block the AV node or slow the AV node, practically speaking. Beta blockers, muscarinic agents, adenosine, and the high vagal tone that slows down the AV node is what causes the bronchospasm. So I tend to remember them by remembering the treatments I give for people to slow down their AV node. And I forgot about NSAID, so I'm really grateful for Alexander to remind us about that today. Okay, y'all ready for the schema? This was inspired by this patient, so I'm really excited to share it with you. Okay, I'm gonna just put it up here for you to look at. Can you all give me a thumbs up if you see the schema? Okay, let me move my screen out of the way. So here you go. One, let me know what, take a look. I'm going to mute for 30 seconds or a minute, actually, just give you a whole minute to slowly go through it. Give me your feedback, and then let me know what you think this patient might have. The answer is on here. All right, here's your final clue. So you go back and you talk to him after he's better, and he says, I've had 4 of these episodes before. Only 4. No symptoms between those episodes. And every single time it happens when I go to my sister's farm, which is up here in about 30 minutes away from our hospital. I've never had these symptoms anywhere else, never get them anywhere else. All right, Alex and Sammy, you nailed it. But I haven't heard Keshav's voice, who just chimed in. Keshav, do you want to share your thought out loud? If you're able to, no worries if you're not. No worries at all. Keshav's on a night shift. Alrighty, I'll have you guys tag team it. Sammy, how did HP come in your mind?
I think of HP with certain expositions, for example, when patients have birds or work as farmers and are exposed to a lot of grass, and then they come in with an acute febrile episode, have altered pulmonary function tests. You monitor them for some hours, it gets better, then you send them home. One day, after they do the same, they come back again and have the same symptoms. And when you have this for a longer time, it can also really cause a restrictive lung disease. So you should really pay attention to that.
Sorry. That was wonderful, Sammy. Thank you. Alexander, what do you have to add to that?
Little to nothing. The only thing I'll say is that Andrew Sanchez, who sometimes hangs out with us on the CP Solvers, put out a good tweet this week, where he talked about imaging findings of some ILD pathologies, and what I think the first comment on his tweet was the imaging findings associated with HSP.
Nice, awesome. Okay, Anita's bringing up some wonderful questions that I think many people have, and many people will have when they listen to this later. Can you just say your question out loud, Anita, so that people listening later can also hear them?
I'm a bit confused between allergic bronchopulmonary alveolitis,
yes,
hypersensitivity pneumonitis, and exogenic allergic alveolitis that Shima mentioned.
Yes. Okay, perfect. So this is going to be a common thing that a lot of people grapple with. So what is ABPA? It stands for allergic bronchopulmonary aspergillosis. It is a disease that has 2 diseases in it, actually. All patients have an underlying obstructive airway disease. Most of it is asthma. The rest of it is cystic fibrosis. So they have that. And only a small fraction of those patients with asthma or cystic fibrosis develop a hypersensitivity to aspergillus. So the reason ABPA gets confused with hypersensitivity pneumonitis is ABPA is a kind of hypersensitivity pneumonitis, but only to aspergillus and only in patients with asthma or cystic fibrosis. And the manifestations and diagnosis of ABPA are similar to HP in that there's an acute and chronic component, but the imaging findings of ABPA are very characteristic and defined as having central bronchiectasis. So those patients have bronchiectasis, usually in the central airways. And they also have prominent either eosinophilia or IgE elevation. They also have a really bunch of fascinating sub-findings, including upper lobe migratory infiltrates, and their sputum, this is a fun list of things, their sputum can be characteristically brown because of the I don't know why, but yes, sorry to mention that. What is hypersensitivity pneumonitis? So what Shema was mentioning is just another word for hypersensitivity pneumonitis, is exogenous allergic alveolitis. They're the same thing. And here is what one illness group towards HP, hypersensitivity pneumonitis. So what is it? It's always about organic material triggering an autoimmune disease isolated to the lung. And the triggers are most commonly birds, pets, or pillows made from bird feathers. This is what this patient has. He was exposed to hay and water. So hot tub or sauna can do it. Admittedly, a large fraction of patients, I think it's around 30%, but don't quote me on that, you never find their trigger. What, probabilistically speaking, what are all of you likely to know about HP is to know the chronic form. And what Alex was reminding us is what Andrew treated about, which is chronic HP, which looks like idiopathic pulmonary fibrosis, a common ILD. That's because most people have chronic low-grade exposure. So what is the exposure intensity? It's low for a long period of time, like your pillow. But a small fraction of patients don't have chronic exposure. They have acute, intermittent, severe exposure, and they present like this patient. These patients are much less common than the patients with chronic or subacute HP. They have no residual lung disease, and they essentially present with anaphylactoid dyspnea with rapid on and off. And as Sammy said, they tend to have some systemic symptoms too, fever, headache, myalgia. The bedrock of diagnosis is imaging findings, but this is skewed towards patients with chronic disease. Diagnosing acute HP is virtually impossible to do with confidence, but requires that history. And the treatment is you remove the exposure, and then you talk about it to everybody you know about it because it's so fascinating, rare, and intriguing. Cool?
Thank you so much for explaining it to me.
Of course. Do you have any residual questions? Nada? All right. Wow. I promised the team that I would do the whiteboard, but I did an abysmal job of that today. Thank you for bailing me out. Before we end, thoughts, questions, and I'll tell you what happened to the patient. Yes, so a recap of ABPA, allergic bronchopulmonary aspergillosis, for Keshav and Keshav only. Two things have to happen. You have to have underlying asthma or cystic fibrosis. A small fraction of those patients get hypersensitivity to aspergillus. Those are the two features required. What does it look like? A chronic progressive lung disease with superimposed episodes of shortness of breath. Clues: central bronchiectasis, atopic labs, IgE or eosinophilia, and then also demonstrated antibodies to aspergillus. You get aspergillus specific IgE antibodies. But the key features are to know this patient has asthma or cystic fibrosis, and they have central bronchiectasis and eosinophilia. All right. Other questions, folks? Thank you, Sammy, typing out those teaching points. Okay. Let me summarize the highlights from today, and I'll let you all go. There are a subset of conditions in medicine for which morbidity is common enough that it should be your first thought. Dyspnea is one of them. And how do you assess severity of dyspnea? It mirrors the pathophysiology. The lungs can fail in two ways. They fail to get oxygen in or fail to get oxygen or carbon dioxide out. And severity is gauged by mapping on to one of those two problems. One of them is very easy. Oxygen, put on a sat, absolutely amazing technological innovation. Think about that. You just put on a little machine and in 5 seconds, you know that problem. Before, you'd have to stick the patient with AVG, wait 10 minutes. Now you can do it in seconds. The CO2 arm, unfortunately, doesn't have any technological innovation. So you have to use an assessment of subjective severity, dyspnea with exertion, dyspnea at rest, followed by encephalopathy. Why? The end stages of hypercarbia the end stage of severe dyspnea is altered mental status due to CO2 narcosis, along with a visual and stethoscopic assessment of lung performance. Does this person look like they're at the end of a marathon? Massive lung expansion, tachypnea, smooth breathing that looks strong versus tight, low, shallow, rapid breaths with abnormal lung sounds such as stridor or wheezing. Two very different patients. The first patient has respiratory alkalosis. Find out why and stop that problem. The lungs are not the problem. The second patient, you don't have much room before you intubate them. Your options are pharmacological bronchodilators, BiPAP, but don't forget to position the diaphragm to help your patient. And you're going to have them sitting up straight so their diaphragm does not have to fight the stomach to move. The stomach is moved out of the way by gravity. Once you understand you have hypercarbic respiratory failure, you need to understand the cause. And we didn't talk about today, but you found a big clue: wheezing. Wheezing equals lower respiratory tract obstruction, which has a wide differential diagnosis. But y'all nailed it. This patient had acute HP, and I rambled too much, so we'll let you reflect on what you learned about acute HP on your own time. But I will lean on my friends here and would love for emphasizing one of these teaching points in another language. So Sammy, do you want to share one? Actually, no, I poked on you a lot. I see Shema's back. We lost you there for a second, Shema. Do you want to share one learning point in German just to crown it out today for our German schemas? What's one thing you learned today in German? And then I will ask, I don't see Rafa here, so maybe I can ask Tiago to emphasize one learning point in Portuguese. And let's see, if you have a learning point in Spanish, please let me know. We'd love to hear it too.
So, and then I say one learning point in German, im Hinblick auf die Sauerstoffsättigung, dass die nicht immer sehr zuverlässig ist. Also immer gucken, es könnte eine Methämoglobinemie sein, wir könnten auch einen niedrigen Blutdruck haben, ein Carboxyhämoglobin haben oder auch bei Raynaud-Syndrom. Genau.
Sounds so cool. I wish I knew anything that you said. Got 0. All right, Tiago, you want to emphasize one learning point in Portuguese? That's okay.
Yeah, I can. Rafa is back. I don't know if he wants.
Oh, amazing. You know, I'm going to poke on somebody who I didn't get a chance to highlight as much. Marcela, do you want to emphasize one thing in Portuguese?
Oh, sure. Então, hoje a gente aprendeu pouco sobre a pneumonite por hipersensibilidade. Não sei se eu estou traduzindo certo. E a gente viu a diferença com a ABPA, que é induzida pelo aspergillus, né? E geralmente o paciente vai ter um histórico prévio de asma ou fibrose cística, e aí quando ele tem contato com o aspergillus, que é um fungo, ele induz essa hipersensibilidade, desencadeia os episódios de broncoespasmo. That's all. Thank you.
I think I understood like 20% of that. It's not bad.
Oh, great.
Oh, Shema did too. Look at that. Anyone want to volunteer to share anything in Spanish? We can't leave without honoring our friends who speak Spanish. It's an abomination. Who will volunteer to say something in Spanish they want to emphasize? Nada? Oh man. Maria's gonna be so mad at me. So mad. Are we all going to leave Maria disappointed and sad? Okay. Maybe she won't watch till the end. All right, y'all. I don't think we have anybody, and that's totally okay. Thank you for hanging out. We have a special neuro VMR tomorrow. If you're able to make it, it would be amazing because Gabby is our beloved team member who's doing her first ever facilitation. So if you can make it, that'd be awesome. If not, we'll see you on Monday for another VMR, subspecialty VMR. Bye.